Hi, this is Nicholas Fogelson from Northwest Endometriosis and Pelvic Surgery. I just wanted to touch on another topic that some people may be interested in. And what I wanted to talk about was the role of pain management physicians in the management of people with endometriosis and other kinds of pelvic pain. Um, so, a lot of times I see online people that have had some benefit from surgery but may have some ongoing pains, and they get frustrated because someone says, well, I'm just being sent to pain management. And sort of the implication of that is like, well, no one's really going to try to fix the real reason for my pain. They're just going to cover it up. And that's considered some really negative thing. I would like to give you a different perspective on that a little bit. When we're talking about endometriosis and pain, there's kind of an underlying cause of things, and then there's the result of things. Underlying causes like endometriosis, inflammation from endometriosis, scarring from endo or possibly from post-surgical scarring, nerve inflammatory nerve compression, different kinds of things. Like these are all, initiating factors of pain, some of which can be addressed surgically and some of which can't. Um, and when a lot of people talk about we want to get to the root of the problem, they're talking about what can we do surgically to address why are these pain signals coming out of the pelvis or wherever and getting to the brain. And so that's one side of it, is that can we fix the fundamental thing? And my experience has been is that for many people we can make a substantial amount of headway through surgical intervention when it comes to endometriosis and pelvic pain. However, you usually can't get 100% resolution of pain. I always tell people that you can't cut pain out of the body. Pain is an electrical neurologic phenomenon that nerves in the pelvis are sending signals of inflammation and irritation up to the brain, and you're perceiving that as pain. Um, so you can remove the things that are hopefully initiating that, but still a lot of times the brain perceives a certain amount of pain, or maybe there's still some inflammation or something still actually legitimately sending that signal, but there still is a maximum benefit one can get from surgery, at which point more surgery is just not going to help and maybe even make things worse. Um, so the pain management side of things is a little bit more along the line of like some of the neuropelviology that I talk about, is not talking about why is the pain happening, but rather how can we get the pain to not reach your brain and so that you can have quality of life. Because ultimately there's a pain signal coming from somewhere, shooting up peripheral nerves, either autonomic or somatic nerves, hitting your spinal cord, going to your brain. When you see it, when you feel it in your brain, then you go, ouch, that's what hurts. But if we can interrupt that signal so that you don't feel it, then effectively you don't have the pain. Sometimes that's as simple as literally cutting a track that the pain is going up. I have had patients that have very specific abdominal wall pains that we can block with local anesthetic, and we know it. And every time we block it, their pain goes away, but you can't get it to go away permanently. And I've actually severed abdominal wall nerves to make areas kind of numb. And that in a very subset of patients that can work. But sometimes pain management doctors will do a variety of things to try to address the conduction of pain up to your brain and therefore your perception of pain and your quality of life. One is the use of pain modulating medications. This is like gabapentin and Lyrica, nortriptyline sometimes. These are medications that actually impact the bioelectrochemical system of how pain gets transmitted to the brain and kind of tunes it down. Gabapentin is a very common one. It's very inexpensive. You can start with low doses and you can go up to higher and higher doses over time, and you can make almost any pain feel much less intense. And if a pain is really because of a neuropathic pain where the nerve is just really irritated, gabapentin is particularly useful. Lyrica is similar to gabapentin. It has probably less side effects, and you can take it twice a day, or actually still usually take it 3 times a day, but it's sort of a fancier version of gabapentin. It's quite a bit more expensive, although it's become generic now, so it's not too expensive. Both gabapentin and Lyrica are definitely neuromodulatory. If you get on a good dose of it and it's helping your pain, if you eventually go off of it, you will have a withdrawal from that. So you have to go off of it very slowly. And then nortriptyline is a tricyclic antidepressant medication that also has an impact on pain, and some people use that. We use that for pudendal neuralgia sometimes. Sometimes we use it for vulvodynia too. So These are medications. Then there are things you can do to directly reduce inflammation of nerves. Sometimes the pain management doctors will do an injection of local anesthetic with steroids around a nerve root to try to just numb that nerve root for 6 or 8 hours. And by getting that nerve pathway to just be quiet and stop sending a pain signal to the brain, sometimes that can give that system an opportunity to kind of reset. If it's kind of hyper excitable, and we can just shut it down for a while. It's kind of like rebooting your computer. Then when it kind of starts waking up again, it may not reawaken in that really excited state. And sometimes doing a block, we know that works to some extent because the effect of a local anesthetic might only be 6 or 8 hours, but a patient says the pain's been better for a week. And it eventually may come back, but something is going on longer than the effect of the local anesthetic. So if we can continue to have that, we can do injections or we can do blocks. Over time, we can get a more extended relief and sometimes even semi-permanent effect on pain. I do that on the pudendal nerve sometimes. I'll do transvaginal pudendal blocks. You can also do transgluteal pudendal blocks through the back. You can do spinal cord nerve root blocks. Those are usually done under fluoroscopy or ultrasound by a pain management doctor. And then people also do peripheral nerve blocks. The pudendal nerve is one, but you can do femoral nerve blocks. You can do you name it, any nerve you can block if you understand how to get a needle next to the nerve. And in fact, those nerve blocks can create profound anesthesia. You can do a femoral nerve block and an obturator nerve block, and you can literally operate on parts of the leg, and the person won't feel it at all because it's just profoundly numb from the block. So then we get to neurostimulation. So there's a variety of techniques of neurostimulation that can interfere with how pain signals get to the brain. The older style of that is called a spinal cord stimulator, where you're literally putting an electrical stimulator on top of the spinal cord, and you're creating a signal that interferes with pain transmission to the brain. That works fairly well, but there's a little bit higher incidence of recurrence of pain or essentially resistance to the stimulator than there is with some of the newer techniques. Part of the reason is when you're putting on electrical stimulation, the theory would be is that you're trying to stimulate the cell body that will be transmitting the pain. And if you stimulate the spinal cord, the cell body is actually all the way up in the thalamus, which is part of where the spinal cord meets the brain. So if you're stimulating down at the bottom of the spinal cord, that voltage has to make it all the way up to the brain to do anything. If you, on the other hand, you can also stimulate something called the dorsal root ganglia, which is actually the cell bodies in the nerve root as they enter the spinal cord. And so you can put a wire right over the top of the dorsal root ganglia, and then you can stimulate it, and you can very selectively stimulate different nerve roots, and you don't have to use really high voltage because you're right on top of it. So you're going to get less side effects. And for some people, they can have a significant benefit, particularly if you can really narrow down. Like if somebody has a somatic pain and you can narrow it down to saying that, well, they have a pain coming from L3 and L4 based on the distribution of the pain. Even if we can't fix the pain surgically per se, you could put a stimulator right onto, say, L3, and usually you get a certain amount of spread around that, and you could knock out those pain signals from those roots. And those procedures, again, are done under usually ultrasound or fluoroscopy, and they'll put a test lead in there, and then you'll wear like a belt pack that it's attached to the test lead, and then you kind of record how much is your pain getting better. And these generators that generate the signals are really quite complex, and the representatives of the companies that make these products work with the patients to change the programs and try to find the settings that give you the best pain relief. And if those things work, then you can go back and put in a permanent lead, and you can actually implant a permanent generator under your skin that is controlled actually with your phone, Bluetooth, and you can basically have that effect perpetually, potentially for the rest of your life. And what I would encourage people is to not necessarily think of like those techniques of pain management as being inferior to addressing the root of the problem, because a lot of times the problem is pain. And so if you can make the pain stop and improve your quality of life, then you have effectively treated the problem, because the problem is pain. It's not necessarily, even if there's some other fundamental reason for the pain, that may not be the way you have to fix it. So I do work with pain management doctors with my patients, and I kind of think of it as an interdigitated thing. Like, I want to try to address the endo, but there may be things that they can do to further improve the patient's quality of life. And there's no reason not to use those things. There's no reason not to think of pain management as like where you go when things have failed. You should more think of it as these are different arms of things that can be done for people that have chronic pain issues. So I think that's important. I think to some extent there's a lot more future in pain management than there is in surgery. And why I say that is like, I don't think there's going to be a lot of advances in removing endometriosis. I mean, we kind of understand how to do it. It has a certain amount of efficiency and effectiveness in dealing with pelvic pain, but it's not perfect. But I don't think that there's going to be some great advances in how we operate. Like neuropelviologic surgery is an advance, and that's something that I've learned and keep getting better at, but it still only affects like a subset of patients. Whereas pain management is an area where there's a lot more to understand about neurology and a lot of study and things that may, like our changing over from spinal cord stimulators to DRG stimulators was like a pretty big advancement in neurostimulation. And now we're actually starting to get onto the frontier of doing stimulating nerves directly with laparoscopically placed leads. And that's something that I may be doing in the future. That's something that is sort of being pioneered in Europe and really doesn't have any place in the United States right now. I would like to be able to sort of experiment with that with patients, but it's not available in the United States at all. But it is available in Europe right now. So I think that there is a future there, and I think that people should be comfortable working with a pain management doctor because I think they may be able to help them. That's just what I had to say. I hope you guys find that interesting a bit. And if you have questions, feel free to leave a comment or shoot us an email. It's nfogelson@nwendometriosis.com. My associate Shanti Moling and I are ready and willing to help. It's like Ghostbusters. We're willing to help you. We will try anyway. And thanks very much. Bye-bye.